Welcome everyone to another vital discussion in neurovascular medicine. Today we're tackling something that's really got the community talking, something that challenges our current understanding, especially concerning medium and distal vessel occlusions, or MEVOs. We've got two recently published RCTs, DISTAL and ESCAPE-MeVO, that have offered some truly intriguing and frankly unexpected insights.
Absolutely, Professor. It feels like every time we think we've got a handle on thrombectomy, a new study comes along and makes us reevaluate. These two trials, DISTAL and ESCAPE-MeVO, really seem to be doing that for MEVOs, which I know have always been a bit trickier to manage compared to large vessel occlusions. What exactly were these trials looking at?
That's a great starting point, Salma. Both DISTAL, led by Marios Psychodios and his team, and ESCAPE-MeVO by Mayank Goyal and colleagues, essentially set out to compare endovascular thrombectomy, or EVT, against standard medical therapy for these medium and distal vessel occlusions. We're talking about segments like the M2, M3, and even branches of the ACA and PCA, areas where historically the benefit of device-based intervention has been less clear-cut than in, say, an M1 occlusion.
So the big question then is whether EVT added significant clinical benefit in these specific anatomical locations. Because, for M1s, the evidence is overwhelmingly clear. But when you get into these smaller, more tortuous vessels, the risk-benefit profile often shifts.
Precisely. And here's where it gets really interesting and somewhat counterintuitive for many of us. Neither of these trials, DISTAL nor ESCAPE-MeVO, found a significant clinical benefit of EVT over standard medical therapy at 90 days. Think about that for a moment. Despite achieving what we'd consider impressive recanalization rates around 70 to 75% with thrombectomy, the patients didn't show a statistically significant better clinical outcome.
Wow, that's a pretty bold statement, isn't it? 70-75% recanalization is nothing to scoff at. We usually correlate good recanalization with good outcomes. So, if we're opening up these vessels, but the patients aren't doing better clinically, what could be going on? Is it a matter of where the occlusion is, or perhaps the type of stroke?
That's exactly the million-dollar question, Salma, and it brings us to a few critical points highlighted by these studies. One of the most striking observations was the high proportion of patients who received intravenous thrombolysis, or IVT, in both arms, and crucially, many recanalizations, even in the medical therapy arm, occurred spontaneously. This really calls into question the necessity of device-based interventions in certain cases of MEVO.
So you're saying that IVT, even without mechanical thrombectomy, might be doing a lot of the heavy lifting in some of these patients. And if the body is spontaneously recanalizing, then perhaps we're intervening unnecessarily, exposing patients to the risks of a procedure without a clear additional benefit.
That's a very astute summary. It's not to say EVT is useless in MEVO, not at all, but it suggests that the interplay between IVT and mechanical thrombectomy in this unique disease subgroup is far more complex than we've perhaps fully appreciated. We've seen the power of IVT, and perhaps in these smaller, more distal vessels, it has a higher likelihood of success, or at least partial success that's sufficient for good clinical outcomes.
That's fascinating. It makes you think about how we triage patients. If IVT is working so well spontaneously in some, how do we identify those patients who genuinely need the mechanical intervention versus those who might do just as well or even better with medical therapy alone? Because EVT isn't risk-free.
Exactly. And this leads us to another significant factor in these trials, the study heterogeneity. Both trials included late window provisions extending up to 24 hours, and they used very broad lesion definitions. They included non-dominant or co-dominant M2s, M3s, and various AP segments. This broadness, while aiming for generalizability, might have inadvertently diluted the potential benefits in specific, more responsive subgroups.
So essentially, by casting a wide net, they might have included patients who were less likely to benefit from EVT, either because their occlusion was too small, too distal, or because they were in a later time window where the salvageable brain tissue was already minimal, and that could mask a positive effect in a more tightly defined group.
Precisely the point, Salma. Imagine you're testing a drug for headaches. If you include people with mild tension headaches who just need a nap, alongside people with severe migraines, the average effect might appear negligible, even if it's life-changing for the migraine sufferers. The same principle applies here. The heterogeneity makes it incredibly difficult to pinpoint specific subgroups that might truly benefit more clearly from EVT in MEVO.
That really emphasizes the need for a more granular approach, doesn't it? Rather than a blanket recommendation. We need to get much smarter about patient selection. Are we talking about better imaging, better clinical markers, or a combination of both to identify those specific patients?
Absolutely. These trials, in essence, do not support a one-size-fits-all approach to performing EVT in medium or distal occlusions. This is a crucial takeaway. It's not about abandoning EVT for MEVOs, but about emphasizing the need for extremely careful patient selection. We need a much better understanding of the interplay between IV thrombolysis and mechanical thrombectomy in this unique and diverse disease population. Maybe it's about identifying patients with larger ischemic penumbra or those with specific collateral profiles or certain types of clot burden that IVT struggles with.
The implication for clinicians in the trenches making these decisions in real time is that we can't just apply the same criteria we use for M1 occlusions to M2 or M3. We need to be more nuanced, more thoughtful, and possibly even more conservative with EVT in some of these cases, especially if IVT has been given and spontaneous recanalization seems likely or has occurred.
Exactly. It really means we need to recalibrate our decision-making algorithms. For example, if a patient presents with a MEVO, gets IVT, and then we see good clinical improvement or partial recanalization on follow-up imaging, the impetus to proceed with EVT might be significantly reduced. Conversely, if IVT fails to achieve any meaningful recanalization and the patient is clinically deteriorating, then EVT remains a very viable option. It's about tailoring the intervention.
And this also means a shift in research, right? Instead of just EVT versus no EVT for MEVO, future studies might need to focus on these subgroups. Maybe EVT for MEVO in patients with poor collaterals, or EVT for MEVO only after failed IVT in X type of lesion. Getting more specific.
Spot on. The next generation of trials will likely be much more focused, driven by advanced imaging and physiological markers. We need to move beyond simply identifying the presence of an MEVO and start characterizing its nature, its potential for spontaneous resolution, and its likely response to different therapeutic modalities. This is where AI and advanced image analysis could play a huge role, helping us to stratify patients much more effectively.
It feels like we're constantly refining our understanding of stroke, and these trials, even with their negative findings, are pushing that refinement forward. They're telling us not what not to do, but how to do it better and more selectively.
Precisely. Science often progresses not just through discovering what works, but by understanding the nuances of when and for whom something works. These trials are a critical step in that direction for MEVOs. They force us to be more critical, more patient-centric, and ultimately to practice better medicine.
So if I'm a neurointerventionalist or a stroke neurologist listening to this, what's my immediate take-home message? Is it to just pause before intervening on a MEVO?
My immediate take-home, Salma, would be exercise extreme caution and critical thinking when considering EVT for medium and distal vessel occlusions. Don't assume the same profound benefits you see in large vessel occlusions. Assess the patient's clinical trajectory post-IVT, evaluate their imaging carefully for signs of spontaneous recanalization or robust collaterals, and engage in shared decision-making with a clear understanding that the evidence for a widespread, standalone benefit of EVT in MEVOs is not there currently. We need to be evidence-driven, not just procedure-driven.
That makes a lot of sense, Professor. It's about being mindful and using all the tools and information at our disposal to make the best, most individualized decision for each patient. Thank you so much for breaking down these complex trials in such an understandable way. This has been incredibly insightful.
My pleasure, Salma. It's an ongoing journey in neurovascular care, and discussions like these are crucial for advancing our field responsibly. To all our listeners, thank you for joining us. Stay informed, stay curious, and continue to challenge the status quo to improve patient outcomes. We'll catch you on the next episode.